Hello, welcome everyone. I am Rachel, Community Manager here at Alloy Women's Health. We are a telehealth platform bringing science-backed, evidence-based menopause hormonal solutions direct to your door. And today I invite you to enjoy $20 off any purchase on our website, myalloy.com, using the code Joseph20. Today I am so pleased to welcome Dr. Judith Joseph to the Alloy community. Dr. Judith is a board-certified psychiatrist. She is chair of the Women in Medicine Initiative for Columbia University Vagelos College of Physicians and Surgeons. She's a clinical assistant professor of child and adolescent psychiatry at NYU Langone Medical Center. Dr. Judith has conducted several clinical research studies in women's mental health as the principal investigator of her research lab, Manhattan Behavioral Medicine. Dr. Judith developed the, forgive me if I'm not getting it right, the T.I.E.S or T.I.E.S method to address mental health symptoms in menopause. We're going to get into that. And she recently received a congressional proclamation from the U.S. House of Representatives for her social media advocacy and research in mental health. Welcome again, Dr. Judith. We're so happy to have you here at Alloy for a deep dive into mental health during perimenopause and menopause. I have to say we got a really large number of registrants ahead of this webinar, which tells me two things. One, that people want to hear from you, and two, that this topic is something that demands and warrants a lot of attention. A lot of women are struggling with their mental health. I have shared that my first symptom when I look back was anxiety. It was certainly not something that I put together at the time, but it was disruptive to my life. And when I began sharing bits of my story, I heard it a lot back from other women. So to begin, if you would just sort of tee us up and explain the connection between hormonal changes during perimenopause and menopause and the onset or exacerbation of mental health symptoms like anxiety, depression, or mood swings.
Well, Rachel, thank you so much for having me and for sharing your story, because I think that when we share, it decreases stigma and it allows us to feel like it's not just us, it's not just happening to me, it's happening to a lot of people. And we all have, experience with hormonal fluctuations because women go through several periods of vulnerability throughout their life. They go through puberty and getting their periods, and many people, some studies suggest that as many as like 80% of people who have their periods have experienced some mood symptoms during PMS. And then there are some people who have more severe symptoms like premenstrual dysphoric disorder, PMDD, where their mood symptoms may actually impact their functioning. So this is, the beginning of the hormonal fluctuations impacting our mood. And then people who are postpartum, who have gone through pregnancies and start to feel different in terms of their mood, anxiety, irritability, interest in things, during the third trimester until after giving birth. Those drops in hormones, those changes in hormones can really impact your mood. And then we see the third type of vulnerability around perimenopause and menopause, where fluctuations in hormones may impact our mood. And so I think that when we talk about how this happens throughout a lifetime, and this is important for us to, number one, name, identify, number two, understand, and then number three, have reasonable ways of coping with, then we are better off. We're all better off. And that's why these conversations are really important. So you're absolutely right. The mind-body connection exists, especially in women related to hormones, because hormones travel throughout the entire body, including the brain. And so you may see symptoms such as anxiety, like you experienced, depression, problems with sleep, problems with thinking, right? These are the symptoms that people find to be problematic.
Yeah, thank you for that. And so just to expand a little bit on how sort of hormone fluctuations or decrease might manifest. I
Mhm.
think, I mention this often as well. This article I read, you probably are familiar with it. It was a New York Magazine article. It was called Midlife Psychosis. And
Mhm.
I don't remember exactly all the details of the article, but I remember reading it at the time and thinking, I had no idea. As somebody who had had bouts of depression in childhood, teenage years, in my early 20s and so on, I don't think I realized even throughout all of that how impactful hormones were. These women, I don't remember how many were featured, maybe 2 or 3 in the article, their lives were upended, their behaviors radically changed as a result, in part, of their hormonal fluctuations. It was really scary. I mean, I think someone ended up in jail. I'm not sure. It was really intense. So could you talk a little bit about that, sort of not to frighten people, but just so that I think people can wrap their arms around the idea that, if I'm really struggling mentally or emotionally, if I'm really, really having trouble with X, Y, or Z, perhaps this is my hormones and I need to go speak with somebody about that.
I'm glad that you brought up your past history, because what I tell my patients and the women that I speak with is that they should know about the 3 Ps, right? If you're going through midlife and you are wondering, okay, is this a major depressive episode or is this related to my hormones? Knowing the 3 Ps can be really important. So number one is period changes. If you're having period changes, that is not a symptom of major depressive disorder. There's something called the DSM-5. It's a diagnostic statistical manual for psychiatric conditions. It's like the Bible of psychiatry. Under the criteria for major depressive disorder, periods don't show up anywhere in that text. So if you're having period changes, you should be asking your doctor, your provider about perimenopause or menopause. Um, the second is physical changes. Under the diagnostic criteria for major depressive disorder, there are no physical changes. And so if you're having physical changes like flashes, dry skin, changes in odor, changes in urination, things like that, those are more likely to be related to hormones, right? And not a major depressive disorder. And lastly, the last P stands for past. So if you have a past history of depression, if you have a past history of trauma, or a past family history of mental health issues, you're more likely to have a recurrence of that in midlife. So you want to be able that you go to your doctor, you talk to your doctor about your past history. And this is tough because a lot of times we know our past history, but we don't know that of our family members. So we may have to go and talk to some of our family members and ask them in a way like, can you please help me? I'm not trying to learn your business, but I
Yeah,
need your help, because
yeah,
people are
yeah,
very guarded, especially some older generations. They don't want to share their business. They don't want their business out in the streets, right?
sure.
So you may have to say it from a different perspective, like, I really need your help. If you could tell me a little bit about what you went through in your past, or if what grandma went through, that would be very helpful for me. And I won't tell anyone else because, just because, you and I are okay with the talking about things openly doesn't, we can't assume other people are. So learn those things, those 3 Ps, and go to your doctor about that. And I think that's a really nice place to start to try to figure out if which one of the two are happening. But
Absolutely.
one,
I'm sorry.
but in general, women are more likely to have depression than men. Twice as more likely to have depression, twice as more likely to have anxiety. So there may be the component of, again, we talked about those vulnerabilities throughout life because of our hormones that sets us up for more of a vulnerable disposition. But knowing that, right, that knowledge is power. Knowing that, we can start to plan. That's where the preparation comes into place.
Phenomenal. Thank you. That's so helpful. So we know, sort of collectively, and certainly here at Alloy, we know that MHT can be so helpful to much of this. I'd love to talk about antidepressants because they get a bad rap. I think they always have. But there is a bit of a tension in the conversation around perimenopause, menopause, and the use of antidepressants. And I think, I suspect, correct me if I'm wrong, that what it's really about is women reporting ad nauseum, shamefully, that their doctors have just tossed a prescription for an antidepressant at them and said, you know, you're good, you'll get through, good luck. And so they're feeling dismissed. At the same time, how do we know when are they in order, and how do we trust that they can be helpful, often coupled with MHT, as I understand?
Yeah, that's a very good question. And I do think that antidepressants get a better rap. Listen, I prescribe antidepressants all the time. And I've seen people really, I mean, have a tremendous response, but I've also seen people have not so great responses. And I think that, you know, using that 3P rule that I just explained is very helpful, because an antidepressant won't necessarily help you with your itchy skin, right? An
Right.
antidepressant won't help you with that urination problem, you know? Some antidepressants may help with hot flashes, but not to the degree of other interventions, right? So you want to think about correcting some of those bodily problematic symptoms first, because if in many cases, if those physical symptoms are improved with hormones, a lot of the anxiety gets better, you know? And so you want to be able to try and correct the fluctuations first. That's the way that I typically approach things. And then if you are still seeing significant mood symptoms and still seeing significant anxiety, then you may want to use things like therapy and or psychotropics. And psychotropics are not just antidepressants. Psychotropics are medications that work on the brain and the mood, and they can be anything from an antidepressant to a mood stabilizer to an anti-anxiolytic or anti-anxiety medication. So you want to first get to the root of the, I think if you're pretty sure that this is perimenopausal mood changes, and you're early in the process, you want to think about correcting things with hormones or considering that first. But if you're continuing and you're working with your doctor and your physical symptoms get better, but the depression is still there, it's still impacting your relationships, it's still impacting your ability to enjoy life, it's still impacting your ability to walk through life and do the things you want to do, that's when, you know, talking to a psychiatrist or a psychologist and discussing, is therapy better for you? Is medication better for you? Is it a combination of both? What is best for you? And I think that's important, because we talk about MHT, but there are medications and hormones that will be best for you that won't be best for someone else, right? So even under the umbrella of hormones, you have to think about what's best for you. Same with psychiatric treatments or psychological therapies. Some may not be best for you and others will be. And that requires that one-on-one relationship with the provider to go through your past history, right? If you're someone who has a past history of trauma, right? And significant trauma and PTSD, well, you know, yes, the hormones may help you, but because, you know, this is a vulnerable time in your life and your past history of trauma makes you vulnerable to your future depressions,
Sure.
you may have to have a tailored treatment with a provider to address the trauma. And that could be medication, that could be special types of therapies. But we want to make sure that we're thinking about you as an individual and not just like throwing things at you because they help someone else, right?
Fantastic. Thank you so much. That's enormously helpful. Dr. Judith, several women got back to me when I invite people to send me questions for you, for people I speak with. They got back to me in my DMs and were questioning their rage, and they use that word. A couple of them also conflated it with dissatisfaction in their marriage, and a couple, those two actually expressed real concern about their ability to hang on to their relationships. So short of an appointment with you, what can you offer these women or anyone else who's listening, who speaks of the rage and particularly the union that it impacts in their life?
The rage is interesting because some people have rage for different reasons. Rage in itself can stem from different reasons. So some people who are very anxious and their anxiety worsens during this vulnerable hormonal fluctuating state, their anxiety manifests as rage. So if you've ever met someone who liked things just right, and then you just came in and you moved one thing and they're like,
Ah.
that's rage related to a very rigid form of anxiety, right? There are some people who are irritable, and their irritability looks like rage in the form of a depressive state, right? So that they are not enjoying things, life isn't as meaningful to them, but they express that sadness with irritability and rage. So that's looking more at the depressed bucket. And then there are others, and I see this with my clients who have ADHD, who have more of an impulsive rage. So the first thing that comes to their mind, they're going to just do it. So you cross them, they interpret something as rejecting, they are like, boom, they go from A to C without even hanging out in B. So we want to understand what that rage is about, because it could be related to other things. That being said, I think that a practice called mindfulness helps with all types of rage. And mindfulness is not something you want to learn when you're full of rage. You want to learn mindfulness when you're in a position where you can actually practice it in peace and master it, right? So you want to think about how you can sit still in a moment and be present, and be able to then pick and choose what thoughts you want to put on a pedestal, what emotions you want to put on a pedestal, and which ones you want to shelve, right? And that amount of agency to be able to pick and choose your feelings and your thoughts, well, you need to practice that when you're not full of rage. So I suggest with my patients that, mornings tend to be best for a lot of people, that they pick a part of the morning to just sit still and be present. And it could be a very simple practice of sipping your coffee or sipping your water, right? I use water a lot to teach mindfulness in my sessions. And I'll, be like, okay, we're going to stay grounded in our moment. We're going to focus on the five senses. We're going to sip the water. And describe how it feels. It's cool. It's wet. We're going to listen to how the nails feel on the glass. We're going to look at the colors, look at the hot pink, or, stay present in the moment. So as you're describing this very rudimentary, basic experience of drinking water, you are being present in the moment. And the more you do that, the more you practice that, you're able to, when you're hit with emotions, when you're hit with rage, you're able to kind of go into the Zen-like, my daughter likes Kung Fu Panda. I think about when he was able to master the dumplings, like you're like, whew, and you're able to master that rage. That when patients get to that point, they're just so grateful, because that's something that you can keep with you for an entire lifetime. Your hormones may stop working, your antidepressant may stop working, but that mindfulness practice, once you master it, you can continue to use that for the rest of your life. So I think that's something that's very helpful, right? So when the husband comes in and he leaves the thing on the floor again, and it's like, well, you're going to go into your little state, you're going to practice your mindfulness, and you're going to pick and choose how you want to react, what you want to do, whether or not you want to shelve this feeling for now or deal with it in the present, right? So I think mindfulness can be very helpful.
I can't help but think as well how helpful it may be in a professional setting. Because again, right, so many women are talking about this thing coming up, whether it's rage or just, I don't know, frustration that feels somehow out of control in a professional environment, being able to kind of like, I don't know, neurologically gear down and be present and focus on something that just shifts all of that. I imagine it's incredibly helpful. So thank you for that so much.
I do think that the hormone, the buckets of rage I talked about, rage due to anxiety, rigidness, rage due to mood, depression, rage due to ADHD, right? I think that with hormones, you get a little bit of both, right? Because when you have hormonal fluctuations in the menopausal mood period, you're having challenges with executive functioning. So that's the ADHD part. You're having challenges with your mood. That's the depression bucket. You're having challenges with anxiety. So you're getting a little bit of each, right? How fun is that, right? So again, having the mindfulness as a tool can address each bucket, but it takes practice, and it is doable, and just about anyone can do it.
Awesome. Thank you, Dr. Judith. another thing we know, but research also indicates that Black and Native women whose experiences are largely marginalized way out of this conversation to date, are not amplified enough. And these women often face unique challenges during perimenopause and menopause, including more severe symptoms, earlier onset of symptoms related to this season of life, less access to healthcare. Could you elaborate on this point and the specific ways in which systemic racism and perhaps socioeconomic factors, weathering, may impact this group of women?
Yes, and I think people are surprised to learn that the highest rates of PTSD occur in African American communities. They're surprised to hear that, because when people think about PTSD, they think about combat. And, I'm guilty of it too. When I think about a veteran, I'm thinking about an older white man, right? But PTSD happens in women, right? Most trauma survivors, especially women, suffer assault. And then Black communities, there's a lot of the systemic racism, the generational trauma from slavery and from systemic discrimination and microaggressions that wear on us every day, right? Black communities and Black people walk around knowing that they're Black and thinking about themselves being Black all the time. Right. I don't think that, many people understand what that's like, right? So that type of stress in itself wears on you. And it tethers you and it wears on your very genes, the thread that makes you a living, breathing human. So there are studies that show that. And so, I think that could be very validating. It sounds like depressing and daunting, but it's actually quite validating, especially with my patients who are Black and brown. And I tell them that, there's a reason that you're going through this sooner, that your symptoms are more severe because of the history of trauma. And it feels more, I think, acceptable when it's like, okay, a whole group went through this, not just me. And studies show that when a group goes through something together, there's more, it kind of lessens the blow. It doesn't eradicate it, but it lessens it versus it just happening to one person. So I think that information is validating. And also that healthcare professionals need to know this. They need to have that in the back of their head that, okay, I have a patient and she's African American and she's approaching her 40s. I have to start thinking about early menopause for her because, right. Black and African American women go through the transition sooner for longer and with worsened symptoms. And so I think that, that's number one. Number two is that there's a very harmful trope, Black don't crack. One of my good friends who's a dermatologist, Dr. Michelle Henry, says, Black don't crack, but it may sag.
Yeah.
And I think that's really funny because
yes.
she will tell me that she has Black women coming into her office who are ashamed that their Black is cracking. And she's like, she has to sit them down and be like, listen, that's a trope. Yes, we have melanin and yes, we are, beautiful and have nice skin tones. But again, the history of trauma and systemic racism and the things that wear on you will hurt you from the inside out. So I think that it's important to challenge those misconceptions because a lot of doctors may not necessarily see that outside of a Black woman and say, oh, I should be screening her for perimenopause because she's in her late 30s or mid 40s and she has time, but it's the opposite. Right. So we have to arm ourselves with knowledge when we walk into our doctor's offices.
Yes.
And we have to educate ourselves because every woman should know that many doctors only get one class on menopause after they graduate medical school. One class.
Which is mind-boggling.
One class, right? And women spend about half of their lives postmenopausal because we're living longer these days. So that is ridiculous. So we have to walk in with that very scary fact and know that we may have to educate our doctors about our own needs because not the majority of doctors don't know what we know because we're in these spaces.
Yeah. Hence, one of the many values of conversations like this, right, is that we're giving access to the masses, women like me who don't know anything, but now can walk in armed with information and alter our own experience that way. Dr. Judith, can you talk about alcohol a bit in midlife, perimenopause, menopause? It gets a fair amount of airtime, I think, but I suspect not enough. We'll hear, like sober in midlife and these kind of hashtags or whatever. So women are aware, but I don't know as much as as we should be. So can you spend just a couple minutes on that, what the impact of alcohol is?
It's interesting because I talked about this with a lot of my clients, and and I put it into the lifestyle bucket because I challenge them and I say, if I went to business school as well as medical school, and I tell them that if my colleagues in business school told me to start saving for my retirement in my 50s, I would be like, did we go to the same business school? I'd be like, were you studying? Were you paying attention? Why is it that we start preparing for menopause in our 50s? So I start with my patients in their 20s, telling them about what to expect, because it's not that it's ever too late, because you see these great like Instagram posts of these women like starting to lift weights in their 70s, and it's awesome. So I don't think it's ever too late, but it's so much better to start preparing earlier. And so one of the things I talk about is alcohol. Like, why would you drink the way that you were drinking in your 20s? Your brain is different, your body's different. It's not going to land the same way. You're not going to be able to get up and go the next day. It's going to impact your mood differently. It's going to impact your sleep differently. Your liver is different. The alcohol is metabolized by the liver. And a lot of times as we get older, our liver starts to collect fat deposits and doesn't work as well. So why would we do that to our bodies, right? Again, that's where the knowledge comes in. And so, the relationship with alcohol is something that I try to talk about. It's a bit taboo for some people because some people really do feel as if that glass of red wine at night is like what they look forward to.
Right.
But as you get older, you may have to change that relationship with alcohol and start to practice other things that you can look forward to, that can help ease that anxiety, that can give you that escape. Because alcohol can worsen your sleep. It can change your sleep architecture. And as you go through these changes, you're going to be more vulnerable, right? This is a vulnerable period. There's no healthy amount of alcohol, unfortunately. I know that in the Mediterranean diet, it talks about red wine and that being okay, but really and truly alcohol is not healthy for you. But that being said, I don't want to be a prude, like you want to be able to enjoy life, but also know the risks, right? That if you're drinking in your during these vulnerable fluctuations, you're going to not be able to cope as well as if you were to abstain. The other thing I talk about regularly is exercise. The way that we exercised in our 20s, being on the treadmill. I go to the gym in my building and I see the majority of the cardio and the aerobic machines have women on them. And then you look at the weight section, it's all men.
Yeah.
And I talk to my patients about this. You want to start lifting weights and building muscle mass, because again, as you get older, those exercises that really helped you in your 20s, as you get older, they're not going to be as helpful. You need to be lifting weights. You need to shift things. I do think that there's like a form of denial that we all are guilty of. It's like we just want to keep doing what worked for us, with ignoring the fact that, well, a decade has gone by, 2 decades have gone by. Why are we still doing the same thing and treating and gaslighting ourselves that we're the same person that we were in our 20s?
Right.
And with alcohol in particular, because I do have some patients who have a history of addiction, and not that people on this call have a history of addiction, but I do find that many times we don't realize what we're using the alcohol for.
Yes.
We're actually using the alcohol as a comfort. And I think that when we use food as comfort, when we use substances as comfort, if we can figure out a way to self-soothe without these things, we're better off because it's more sustainable. And alcohol is one of those things that the more you use it, the more you need to get the same high. So you want to
Right.
understand the same with food. You want to be
Yeah.
able to understand your relationship with the substance so that you feel as if you have a say, that you have a choice.
Terrific. Thank you, Dr. Judith, for that. Okay, I'm turning again to a question. And then for those of you on the call who have dropped questions into the Q&A, thank you. And I will get to them in the next few minutes. Okay, so someone asks, understanding what causes the low mood and the depressive-like symptoms. Is it highs of progesterone or lows? Can it be countered by higher estrogen during those days? This woman goes on to say that she's been on HRT for over a year, a patch, a pump of testosterone, progesterone IUD, started with oral, but felt low mood side effects, switched to vaginal suppositories, and then an IUD. I don't feel depressed most days of the month. I enjoy my life more or less. I'm content in most ways, but I get really bad low days for 1 to 3 days sometimes. I'd say 4 times over the past 8 months. That's pretty specific. So answer whatever you can.
That is specific. I don't know the details of this individual, but the studies show that the fluctuations and the
Yeah.
frequency and fluctuations are where the mood issues happen. And it's really hard because your doctor isn't testing your hormones, and like there are no valid tests yet for that. So I want to understand what this person is going through on those days. And for my patients, I suggest having a journal.
Mm,
So not just journaling when you don't feel great, but journaling when you do feel great, so that
mm,
you can bring that journal in to your doctor and go through those days with your doctor. The days that you felt great, what was going on that day? The days that you didn't feel great, what was happening that day? And that sometimes gives you so much information because it's like you're studying yourself, you're cataloging yourself, and it empowers you because you feel as if you're doing something
mm.
versus the very unpredictable and spontaneous and scary nature of not knowing when these days are going to happen, right? So I would start there because you may find that on those days that you're having more lower moods, there could be something else happening. You could be possibly having more physical symptoms. You could probably be having worse than sleep. Maybe there are specific triggers, right,
Yeah.
that are unrelated to you. It could be a person, a toxic individual in your life.
Mm,
I talked about alcohol. We didn't talk about smoking, but those are toxic habits. But there are toxic people, and toxic people can worsen your symptoms during perimenopause. And so you want to think about what's happening on those days and catalog it, because I think that information is very valuable, not just for the person, but for the provider. And then it gives you maybe a plan, because if you can address some of those different contributing factors, then perhaps you can have more agency and control over where your mood lands.
terrific. Thank you. A question came in. This woman says, I am an HSP, highly sensitive person. Is that correct? And perimenopause has been dreadful. I am miserable. Can HRT help?
I mean, you know what? People with HSP or people who are highly sensitive, a lot of times they have co-occurring ADHD. And again, it may be helpful for you if you are vulnerable to hormonal fluctuations. But I also do think that practicing certain types of therapy modalities can be very, very helpful. You talked about the T.I.E.S method. So I coined the T.I.E.S method to help people to understand what the symptoms are to look forward to. So
Sure.
that the T in T.I.E.S is thoughts or thinking, right? The brain fog, tip of the tongue, losing what you're going to say, being forgetful, problems with calculation and memory. And then the I is the identity issues. Like, I don't know who I am anymore. I feel like I don't know who I am. An article recently came out about that. Um, Emotions, and that encompasses the anxiety, the depression, and sleep. And sleep ties all of it together. And, so I think that knowing these symptoms and then being able to address them is very, very helpful. And so, I think that, in terms of being rejection sensitive, yes, that trait, that characteristic is one of the things that people report, and they're more vulnerable if they're experiencing hormonal fluctuations. Mindfulness again can help because
Mm.
when you perceive A to mean C when it really isn't, if you're able to stay in the moment, practice your skills, and then respond, and then choose what thought you want to put on a pedestal, and then choose what behavior you want to engage in, that can help a great deal. And there's a type of therapy called dialectical behavioral therapy
Yeah.
that has been around for ages. It's based on a combination of cognitive behavioral therapy and Eastern philosophies.
Mm.
And it is very helpful for people who are highly sensitive, because what we find is that people who are highly sensitive have a lot of interpersonal, so person to person conflict.
Mhm.
And, it becomes chicken or egg. What's causing the rejection? Is it the conflict, or is it me reacting to this person in a
Right.
perceived way, because I perceive a conflict? So dialectical behavioral therapy and that a specific component of that mindfulness can be very, very helpful.
Thank you, Dr. Judith. I'm going to turn now to some of the questions that are in the Q&A before I circle back and wrap us up soon. Here's one. Is it okay to take estrogen with antidepressants? You answered this, but if you could go on just a bit. Also, I noticed progesterone makes me very depressed.
So everyone's going to have different needs. And I don't prescribe hormones. I work with colleagues to do that, but I do work with them hand in hand as they're prescribing the hormone and I'm prescribing the antidepressant and also doing the therapy. And so it really does depend on you. And for some people, they may need the hormones first and then add on the antidepressant. And for others, they may have already been on the antidepressant,
Right.
and then you're adding on the hormone. And then, there are cases where you have to switch up both, right? The one that worked for you at one point, either the antidepressant or the hormone, may not continue working for you. And so having that relationship with providers that you trust, that you have an open communication with, is really helpful. And there are situations where you don't see your doctor for like a whole year. If you're someone who is particularly vulnerable and having lots of bouts of depression, crying, insomnia, anxiety, you may want to consider, okay, if it's hard for me to reach this doctor, if I leave like 10 voicemails and I don't hear back from them for like 2 weeks, maybe it's time to look for someone else because I may need more attention right now. For others, having a doctor like that is totally fine because they're fine on their regimen. They don't need many changes. They're comfortable with their doctor. They don't have to be seen as often. That's fine. So know yourself and validate yourself, right? Don't tell yourself, well, I wish I could be like that lady over here who only needs to see her doctor once or twice a year.
Right.
It's okay with being different, right? You have different needs. You're different individuals. And so if you're having, these worsened symptoms and you're not able to have a communication with your doctor, you may need a different team. And that is okay. A lot of us feel guilty when we move on from one doctor to the other. But I can tell you, doctors would prefer you to have the best care and to see you in better hands if they're not able to see you as frequently. It doesn't mean the doctor's bad. It doesn't mean that they're unethical. But some doctors have clinics where they have so many patients, they can't give you what you need. And having that open, honest conversation with that office is going to help you get the care that you need at that point in time.
Thank you. Have there been any studies for bipolar disorder and perimenopause, as in whether to increase psych meds or if hormones help? This is a great question.
So there needs to be way more research in terms of bipolar disorder and other conditions. But again, hormonal fluctuations can worsen just about every condition. So, ADHD worsens, bipolar mania could worsen. And so, in those cases, you want to consider whether or not this is something that is very serious, because some people unfortunately do have increased suicidal ideation and hostility and aggression. You talked about the case where someone got arrested.
Yeah. Yeah.
But usually this is not just out of the blue. This is someone who's had a history of having these worsened symptoms during former hormonal fluctuations, right? So these are people that I've seen in the past who, after a postpartum, after they give birth, they're having psychosis. So
Mm.
if someone has a history of that, then I would say, as you're approaching perimenopause, that's when you need to start talking to your doctor about like having more frequent check-ins, right? And you may say, oh, like, well, that was when I, was in my early 30s and I gave birth to my baby and I'm fine now. I haven't had that for years. It doesn't matter. If you have a history of having these vulnerable mood periods where you're engaging in behaviors that are uncharacteristic of your typical baseline self, then your doctor should be planning ahead. You and your doctor, you and your family should be planning ahead for this. And it's always better to plan for the worst,
Yeah.
to have your appointments lined up, your therapies lined up, your consultations lined up, and not have to need them and say, actually, I'm good,
Sure.
I can cancel it. It's better to have that than to be in crisis and then need to call someone up and then need to plan. And then everyone's like booked out for like 6 weeks, right? So as much as you can anticipate it, try to plan around that.
Terrific. Thank you, Dr. Judith. I just want to read this comment to you and then I'm going to ask another question. Thank you for talking about PTSD, trauma, and dealing with medical issues as a Black woman. I just started experiencing hot flashes and missing my cycle, so this is brand new to me. Working out and yoga has been helpful, but I felt at a loss this week emotionally and mentally. Listening to this session is truly helpful and makes me feel like I'm not alone. So thank you for that. This question asks, I have noticed that my anxiety is much worse at a certain time after I wake up in the morning. It's like a cortisol surge. I have increased I'm not sure what she meant to say, psychological symptoms of anxiety. Why does this occur? How can I combat it?
A lot of the morning symptoms are related to the behaviors the night before. And
Hmm.
so, what I really encourage is, in the T.I.E.S method, to look for the S part, the sleep, to really look at your sleep hygiene first, right? Many of us are tempted to be on our phones because that's our unwinding. But that phone, it does more than what we think it's doing. Those images that our brain sucks up, those are getting buried into our unconscious, subconscious mind, and they're living there and they're excited while we're asleep. And
Right.
so, we can't tame them. But what we can tame is our ability to be off of the phone after 9 p.m. And it's very difficult, very, very difficult. So a lot of my patients will put the phone in another room. They will silence it, they'll dim it. But that really, I think, lately has been the most disruptive in terms of the sleep hygiene. The other thing is that because of the physiological changes that happen with hormones, your body temperature changes as well. So you want to keep the room cool. And that simple intervention can really help a lot of people. Even using the right sheets, soft, soothing sheets. I joke because when I was in medical school, I was on a tight budget and I would like buy the cheapest sheets, and now I have like the nicest sheets, like invest in really nice sheets
It
and in
makes a
nice
difference.
PJs. Your
Yes.
sleep game should be on. Like
Yeah.
you should really work on the sleep game because it makes
Yes.
a difference. And also from a behavioral standpoint, when you're making your bed cozy and luxurious and you're doing this little haven for yourself, it sends a message to you that you're worthy of this, that you've made it through another long day. You deserve this palace of a bed to just relax in, that is not interrupted by a device, right? That is comfortable and soothing. And we talked about the grounding and like the senses, like it should be so pleasing to the senses that it invites you. But many of us sleep on our sleep game, no pun. Well, pun is actually intended.
Yeah.
The other thing is that many of us eat very heavily late at night. And so, I think that not having foods that are greasy or heavy, because as you get older and as you go through perimenopause, acid reflux can happen, and sleep apnea can happen, right? And so we want to make sure that we're addressing these sleep issues, because sleep feeds into the other aspects of T.I.E.S. Good sleep means that you think better, your cognition is better. Good sleep means that your mood is better, your anxiety is better. So we really want to focus on sleep with all angles. And also, in terms of sleep, studies are showing now that it's less about the amount of sleep, it's more about the routine. So you want to try your best to stick to a routine. And so a lot of us are tempted when our favorite show is on to stay up and watch it, but put it in the DVR, just make sure that you're sticking to the regimen as much as possible, because as you get older, you're more sensitive to even a change in 1 hour, right?
Yeah.
So that routine is very, very helpful. I find that when I work with my clients on their sleep routine and their nighttime regimen, that helps the anxiety. The other thing is that many people have worsened anticipatory anxiety as they age, because they have more and more responsibilities, right? So women are generally the caretakers. They're working, they're taking care of elderly parents, they're taking care of children. So there's just a lot on your plate. So the anticipatory anxiety gets greater and greater as you get older. So that waking up, you're like that jolt of anxiety. A lot of people experience that. So what you want to do to prepare your brain for the next day is set up your schedule. So what I recommend with my clients who have anticipatory anxiety is I'll say, okay, well, around like 6 p.m., let's look at your schedule for the next morning so that you know what your first meeting is. So you know what your 8 a.m. to 12 looks like. So you're prepared and you're like, okay, I can handle that. The worst thing you can do is not look at it and then wake up like, I wonder what my schedule looks like
Right.
today, right?
It
So
gives
that's
me
a very
anxiety thinking about it, actually.
it is. It's a very
Incredible.
simple intervention. And then as much as you can, plan for the first thing in the morning. So if you can prep your purse or I have like a briefcase, prep it beforehand, put the clothes that you're going to wear out, because executive functioning issues, the thinking part of T.I.E.S, it can make you a bit slower and more disorganized initially. So you want to put your clothes out. You may want to get rid of the cluttering, because having a closet full of all these choices is not a great thing sometimes. So as much as you can, plan for the morning of, and wake up if you can earlier. So you may have to reset your clock so that you're waking up earlier to have more time, because rushing and forgetting things can set you on the wrong path for the whole day.
Thank you so much for that, Dr. Judith. As you've been speaking over this almost 50 minutes now, I find I'm thinking a lot about perhaps the loneliness of some of this, right? When you're going through perimenopause and menopause, maybe or maybe not, you're talking about it with friends or family members. It almost doesn't matter because your experience is solely your own. And if you don't know anything about it yet, it can be enormously isolating, I suppose. And so I'm thinking about, the importance of social support, and if that might weigh in at all and be helpful to our minds, our mental, emotional state.
Absolutely. We talked about the habits, right? Like the toxic habits and the toxic people. Well, getting rid of toxic people helps, but also investing in the people who support you, who are consistently showing up for you, who make you feel as if you belong to a community. Those are the people that you want to put more effort, place more time, put more of your resources into. And the tendency, especially for women, I think, or a lot of the women that I encounter, is that we tend to gravitate towards the girlfriend who doesn't want to be around us, right? It's like that rubber band effect, like, oh, they're elusive. I want to be cool. I want to be in with them. But as you get older, again, those things that worked for you in your 20s, they don't serve you. And so maybe that girlfriend who is elusive and who just like responds to you whenever it's convenient for them, but it feels as if you're kind of like not a priority. Maybe that's not the person you should be pouring your resources into. So I
Right.
encourage my patients. I just had my newsletter last week. I encouraged my followers to do an exercise where they list the friendships in their lives, and pick one that's been a friend that's consistently showing up for you, and really think about it. Have you been investing in that friend? Are
Hmm.
you showing up for that friend the way that they do for you? Do you tend to run after those friends who kind of ignore you because you don't want to have that FOMO? Like, really think about the people who feed your soul, your spirit, and show up for you. And those are the people that you should be investing in as you get older. Because the Surgeon General, Vivek Murthy, just put out a book on loneliness and talks about how loneliness impacts every aspect of your health. It
Hmm.
impacts your symptoms of menopause. It impacts your heart health. It impacts your brain health. It impacts your physical activity. And so you want to enrich your lives with good, non-toxic individuals. So, some of you listening may be like, well, I can't really think of a friend like that. Well, there are communities of like-minded people out there. And many of my patients find that in charities, they go and start volunteering, or they join faith communities. And so examine your relationship with the people in your life. Do you tend to gravitate towards toxic people? Why is that? Do you have a history of trauma where you grew up being neglected and abused, and that's what your definition of love is? Start to challenge it. It's never too late to change the way that you love and attach. There are great books that talk about how you attach. There are great books that talk about toxic individuals and how to heal. It's never too late to start your healing process.
Amazing. Thank you. Before we wrap up, you mentioned this sort of threaded throughout this conversation, but the other side of this coin, the other side of the mental, emotional sort of health of us throughout perimenopause and menopause, and that is this sort of, growth, alignment. We see a lot of, maybe it's a trope, but I don't really think so. We see a lot of this women sharing the idea that they just don't give a bleep anymore. They're done with the ties that bind, if you will. And I wonder if you can just kind of, a lot of this can feel very heavy and saturated, and there may be a lot to sort through hormonally and otherwise, but there's also something else that exists. And if you could just share a bit about that and maybe how to get there.
I do think that we are experiencing this type of like renaissance because we are at an age where we have the internet, we have social media. And I think that, again, back to your point of loneliness, I think maybe 20, 30 years ago, people felt so lonely in their process and in their experience that they may have focused on the negatives and may have completely disregarded the positives that happen in midlife and beyond, right? And that's just human nature. We tend to focus, if we get straight A's, we tend to focus on the 1B,
Yes.
right? If we get
Yeah.
a glowing report from all of our bosses, and then there's one thing to work on, we focus on the one thing to work on. But that's human nature. And I think women in particular are acculturated to scrutinize themselves and to want to be perfect because it is a man's world, unfortunately. But I do think that because of social media and because of the internet and having information and seeing stories online of women who don't give a bleep, right? Who are like, you know what? I'm actually thriving now, right? I think that has allowed us permission to look at the positives, to celebrate the wins. And it doesn't invalidate the fact that there are negatives, but I think we're seeing more of a two-sided approach. And I
Both.
don't like the word balance, but I do think we're seeing more of both sides of the scale. Whereas before, when we're lonely and we don't know what everyone else is experiencing and no one's sharing because we didn't have access, right? And no one was talking about it. I think before it was much more, oh my gosh, this sucks.
Yeah.
Like I'm alone in this and no one's talking about it. But
Right.
the community is very powerful. And we talked about trauma, right? It can be traumatizing if you're going through something and you think it's just you. You're like, what did I do to deserve this? It must be me. And the shame and blame and guilt, those are symptoms of trauma. Those are trauma responses, right? But if we know that like many people are going through it and they're sharing it and they're talking about it openly, that decreases the shame. It decreases the blame because it's not just you, it's many people. And then we're able to look at things from all perspectives. We can see the good and the bad. We're not just picking one side because we're seeing all sides.
Fabulous. Dr. Judith, I'm taking advantage of the clock behind you, and I'm going to ask you one more question that someone wrote into the Q&A, because I think it's pertinent certainly to this conversation. With antidepressants for the SSRIs and down-regulating serotonin, doesn't that affect the uptake of HRT hormones and melatonin for sleep? This question is completely foreign to me, but you would be the person to ask.
So I think that, again, every person is different. I've had people who were on SSRIs and really felt like, oh my gosh, it worked really well with my hormones. And others who are just like, I can't, you know? So, but I do think we need more research in it. And what you're asking me is something that is so like biochemical and so like precise that requires a lot more studies. Um, and every individual is different. And so I do think having more options and knowing that this exists as an option is very helpful. I do a lot of studies with postpartum depression and looking at neurohormones. And I do think that that's an entire landscape that we're going to be able to see more research in. And that's not an SSRI. It's not a hormone in particular, but it's a neurohormone. It works in the brain similar and trying to, even out fluctuation. So I do think that there needs to be more research. And what I would say to this person is, rather than trying to figure out what's happening with this, is it going up? Is it going down? Try and write a log as to how you're feeling when you're taking these medications, right? Try and see, okay, if I took this for 6 weeks, what symptoms got better? And there are great rating scales that patients can use to parse out their symptoms of depression to see, and this is what I use in my practice because I run a research lab. In order to see if someone's getting better or worse or staying the same, we do clinical rating scales. So some of them are clinician administered, meaning I administer them with the patient, and some of them are the patient filling them out. And in your practice, in your private practice where you're seeing your doctors, they may have access to these scales, so you can actually fill these scales out and take a log as to how you're doing and look at specific symptoms of depression or anxiety to see which ones are getting better, which ones are getting worse, which ones are staying the same based on your treatment regimen over time. And it could be that it has nothing to do with the medicine. It could be something happening in your life
Right.
that is, or lifestyle changes,
Right.
or the people in your life or situations that are impacting the way that you respond.
Dr. Judith, this has been an amazing hour. I'm enormously thankful that you joined us here. I'm thrilled to welcome you to the Alloy community. I hope that we get to speak again soon. As I said, I don't know if I said at the beginning of the call or before we started the call, but I do feel deeply, deeply that this part of our perimenopausal, menopausal, midlife journey, if you will, can't get enough attention. And I'm just so glad that we really kicked this piece off in earnest with you. So thank you very much. And thank you to everyone who joined. It was just wonderful.
Well, thank you for having me, Rachel. It's always good to see you. And thanks for your advocacy work. It's really important and needed. And being open and honest about your experience helps so many people. And so sharing your story and listening to others and then learning from others and having community is how we all heal. We don't heal in silos, we heal in communities.
Yeah.
So
All right.
thank you.
We did that. Thanks so much. Thank you, everybody. Be well.